So a quick line on neuroradiology in terms of that. So we got essentially when we look at neuro-ophthalmology, in terms of the radiology aspect of it, we have the X-rays which are going to help us catch any gross fractures in the skull. But essentially, you got the CT scan and you got the MRI. CT scan is going to be used where you want to look at the bone, where you want to look at any acute infarcts, any bleeds in the system, when you want to look at the orbit. If you're looking at soft tissue changes, demyelination, inflammation, edemas, that's where the MRIs come in. And within the MRIs, you have flare imaging, which helps with the demyelination. You've got the DWI, diffusion weighted, which is helping with the ischemia. And so therefore you need to know what you want to order, and you also need to look at contrast, because that's going to help you pick up the the inflammation early or any pathology early. So essentially these are the tools and armamentarium that we use for the neuroradiology. So now let's come on to neuro-ophthalmology, and I'll do some cases rapid fire. These are all simple. I mean, these are all cases that we'll come across, the classic cases, and we'll get some pearls from the co-instructors, our experts right here. So the first case is a young female who's presenting with an RAPD in the left eye. There was a subacute vision loss. You can see that the left eye vision is lower than the right eye vision. The color vision was affected in the left eye, and this was out of proportion to the vision. And the fundus that we can see here is showing a edema or a hyperemic looking edematous disc that you can see here. So this is similar to what Dr. Rohit had presented earlier, and these are cases of papillitis. And so Professor Rohit, how would you investigate this patient, and what would you do about it next?
So a young female, sudden loss of vision, moderate to severe left afferent pupillary defect. You have color also affected, although with that vision anyway color would be affected, so you need to actually ask how much more severe, or what is the amount. Is it more than you're expecting it to be more? The rest of the fundus is essentially normal. The neurological exam is normal. So we have all the information that we essentially require. My differentials are going to be optic neuritis as my first go. Of course, we need to do the visual fields as was discussed of the other eye. In fact, the moment you have an affected eye, the most important investigation to do is to do the field of the other eye, so that you are sure that you are now dealing with an anterior visual pathway defect, pre-chiasmal. If the other eye, right eye visual field is absolutely normal, I'm thinking of the optic nerve involvement in the left eye. My first differential is going to be optic neuritis. If I suspect that, my first investigation of choice will be an MRI, brain and orbits with contrast, fat suppression for the orbit and flare for the brain. This is going to give me an idea about the optic nerve involvement in the left eye, and if there are any other features in the brain which may be suggestive of multiple sclerosis or NMO. First intervention is going to be IV methylprednisolone as mentioned for 3 days, and depending upon my response, I'm going to take a call on what other investigations I'm going to do. First event, I may not, especially if the vision starts recovering, I may not do too many extra tests, but I will discuss with the patient the risk of recurrences that they may be there. Give an IV methylprednisolone for 3 days with an oral taper. If she recovers well, just follow her up, and then of course advise her for recurrences, and take it from there.
Perfectly.
MRI must be done now in the first episode. Suspect neuritis or any optic nerve problem, must an MRI, brain and orbits with contrast, fat suppression for the orbit, flare for the brain. If you can't remember all this, MS protocol. It's called a multiple sclerosis protocol of an MRI.
Or you can tell the radiologist that you probably are suspecting inflammation, and they will be able to do it. And the things will change. So beautifully summed up for this patient. But just to extend a little bit more, if the visual acuity was very poor on presentation, if there was a bilateral presentation, or vision did not improve, as Rohit mentioned, that all this is when for this patient when vision improved. But if that didn't happen,
this is the case that we're looking at now.
Okay.
This, in fact, Dr. Rashman only has to discuss for us. So this is a patient who's got, who's having a vision which is very poor. There is a bilateral swollen discs that are appearing. There is a papillitis. Again, it is it's a female in that age category. You can see that there is an involvement of both the optic discs or the field in both the on both the sides. There is an edema on the OCT. You can see that there is a delayed latency in the electrophysiology. So all three of these are helping us, with our diagnosis. Now you look at the MRI, and you can look at both the optic nerves are showing enhancement. There are thickening right up to the chiasma. You can see a lesion on the cord as well here that's there. And so yeah, and you do some tests called the MOG, and it turns out to be positive in this case. So this is now for you, over to you, Dr. Ashwin.
Thank you.
Yes.
We didn't plan it, but it
It
happened.
was
that
not
way.
planned.
So this actually highlights what Rohit was saying and what Ankur mentioned, that we have to do MRI for everybody. Why? Because in this patient, it turned out that the optic nerve is thickened. So that's called perineuritis, which is very suggestive of MOG positivity. Now contrast it to somebody who had a lesion but much more posterior, like lesion which involved optic tract, lesion which involved hypothalamus. Then you know that you're probably dealing with NMO related optic neuritis. Why we need to know about these two, especially NMO, is because they are much more likely to develop paraplegia, number one. Number two, these are the patients who will require steroid sparing immunosuppression for a very long time. Also, these are the patients who nowadays neurologists would be very aggressive to go through plasma exchange therapy, because if Plex is done early enough, probably you have saved. We don't know whether we'll be doing anything with the vision, but at least we know that we have saved the morbidity, the neurological long-standing morbidity for this patient. So I think that's what it highlights, both these cases, MRI, brain in orbit, what Rohit said, for everybody who you suspect as having optic neuritis. Poor vision, bilateral involvement, any other neurological problems, you have to be even more aggressive. Get the neurologists on board if we are not really expert in dealing with it, and tell them that this can be antibody mediated optic neuritis. There are two antibodies that we now know, which is NMO and MOG. MOG, as I said, MRI would show thickened nerves. NMO, the MRI would have a lesion which is much more posterior.
Yeah. All right. So let's come to this another case. Now here you've got a male patient who's presented with subacute gradual onset of vision loss that is happening over time. He's been on ATT. He's been taking ethambutol, linezolid. You can see that the discs are getting, there's a temporal pallor that is developing in both the fundus, both the optic nerves. When you look at the fundus, there is a color vision defect as well. So, and you look at the visual fields, this is typically what you're going to be seeing are these central, or these central scotomas that are there in both these. So you can see a depression in the central visual field. So this is a case of toxic optic neuropathy. Dr. Ankur, how would you approach this patient, and I mean, how would you manage him?
Whenever we have these patients, we have to first look in terms of kind of finding out whether the disease is causing the problem or the drugs are causing the problem. And we know the disease also is bad and the drugs also are bad. But most of these patients do have ethambutol in their part of ATT, and these days we have the treatment protocol which gives the ethambutol for a very long time. And these patients have never been screened or been assessed ophthalmologically before the start of ethambutol. So ethambutol, linezolid, they are all known to cause these optic neuropathies. So the first and foremost, as is written correctly, is like you do a visual field. Visual field will help us find out the etiology that it is looking like a toxic optic neuropathy. The first thing is to stop the errant drug, which is ethambutol or linezolid, and maybe give them multivitamins, vitamin C, ubiquitin, and all kind of support in terms of nutrition, antioxidants, good diet, so that at least some recovery can happen. And usually some recovery does happen if the insult is not too for a very long time. And then discuss with the physician also that they can substitute some other drugs, sparing these drugs from their regime, because you don't want to have an MDR or difficult tuberculosis for these patients.
Anything you want to add?
Just one more point. I mean, he summed up everything, but it appears now, I don't think I can quote any study or I'm aware of it, but it appears that adding zinc to your multivitamin seem to have a role here, because it boosts up mitochondria.
All right, so let's look at these videos of this patient who's presenting. You can see that there's an abduction defect. You can see some nystagmus that's happening on abduction in the right eye. Let's look at the other. The other one's not running. So whenever you're getting these ocular mobility problems, the otherwise the deductions on their own, they seem to be working okay, but it's only in one case. You're getting an adduction defect in left eye, you're getting an abduction nystagmus in the other eye. So these are, when you're looking at extraocular motilities, you can actually look at changes, you need to evaluate both the ductions and the versions. You also need to evaluate convergence or near reflex. So these are situations which are basically going into, the IN or the internuclear ophthalmoplegia. So how would you, Dr. Mahesh, how would you look at, what would you do next to evaluate something that looks like this for you?
Yeah, so she's an young patient and it's a bilateral internuclear ophthalmoplegia. So by teaching, we think that usually it could be a demyelination in the young patient if it is bilateral, but then but in any case we need an MRI as has been rightly done. And in this case, since she is an young diabetic, she has unfortunately developed this infarct in the brainstem, and we need to immediately refer this to the neurologist for heparinization and anticoagulation, and that is what we would do, and earlier the better.
And if it was a demyelination, then of course we want to
steroids we would give.
Look at steroid therapy.
MS protocol. So MRI is mandatory as has been done already, and for the residents, for teaching purpose, they need to know what is an anterior internuclear ophthalmoplegia and posterior INO, where convergence is spared or convergence is affected. Anterior meaning that midbrain, and posterior meaning that because the MLF is long, it extends from the midbrain to the pons, and it could be affected anywhere, sparing or involving the convergence.
Right. All right. Let's look at this. He's a young male, otherwise overweight, obese. Was taking, lots of. He was on, doing a lot of gym training. He was taking certain forms of steroids and all to enhance himself there, and he presented to us with. These very, very swollen-looking discs in both the sides. You can see very frank, papilledema with these peripapillary hemorrhages all around. And he was also, on some other medications that he was taking for another hormonal issue that he was having alongside a lot of the other things that he was taking. You can see that the vision was less. So this case, and when you looked at him, between the first visit that he made to me, I'm showing you two fields, that are just about a week apart. So this fulminant kind of papilledema, look at how quickly the discs, how quickly the field has constricted within a period of 1 week, despite starting him on some kind of a therapy. So these are, so how would you, Dr. Ashwin, how would you evaluate this patient? What would you do next if somebody like this presents to you with a sudden severe papilledema, fulminant papilledema, and worsening?
So I think one important message is that these kind of patients can actually progress very fast, very, very fast. It is potentially blinding, so we have to act very fast. The investigation would be MRI and MRV. You are looking at thrombosis of the venous sinuses. You need to get a neurologist very early in the management. I would say that if the fulminant papilledema, if the visual optic nerve function tests are deteriorating very fast, these are the cases where something interventional apart from Diamox maybe, because Diamox may not really get him back quickly. So now what are the interventions, surgical intervention which can be done? Optic nerve sheath fenestration, if you have access to it, it is believed that optic nerve sheath fenestration is a transient temporizing matter, but in these patients at least you are arresting a further vision loss. A lumbar drain to say that get the pressure down, or even the shunt. Now VP shunt and LP shunt, you have to remember that these patients can have a slit ventricle, so though VP shunt is more preferable, but it may not be possible. So LP shunt is what can be done. So I would say that a very aggressive intervention is required, and most of the time they may end up having a surgical intervention.
Absolutely. So this is absolutely right. So there was a venous sinus thrombosis that had developed actually, and he was one of those situations who was not overweight actually because of fat, but because of having bulked himself up that much. And this is a case where we did an ONSF, because while they were still tackling the venous sinus thrombosis, we didn't want him to completely lose out all his vision, because that takes time from the neurologist standpoint. And he's been doing okay after that for us. We'll come to any questions so far. Anybody wants to ask something? We'll come to our last case, I think, and then we'll take any questions. So this is an elderly male patient who's presented to us, who's had headaches, temporal headaches, jaw claudication, high ESR and CRP, as you can see. I'm just trying to put the typical classical pictures that you will get, with a vision loss in both the eyes and a severe vision loss in both the eyes. And look at what's happening to him over the next few days, even as we are treating him. he starts with a disc which is looking, edematous, margins are blurred. Bilaterally, one of them is already developing pallor because by the time he realized he has a problem, one disc was already fairly affected. And over a few days, just look at, this is hardly a few days, how the severity of the pallor, the palate disc edema that is actually setting in. And he's got this inferior altitudinal defect in one of the eyes. We could only capture that. The other eye vision was too low to do any visual field. So what would you look at doing in this, Dr. Rohit, Dr. Mahesh, if you could both weigh in?
So, when you look at the patient profile, it's an ischemic optic neuropathy. You would, at the severity, bilaterality, age, that severe palate disc edema, as we had talked about, would consider arthritic as a predominant cause, and that's the most important thing you need to do. You need to do the, as mentioned, ESR C-reactive protein, and also platelet count. These are the three things that can help. Temporal artery biopsy, we haven't been doing because one, we lack the expertise, and two, there are so many skip lesions that you can miss, and you're never actually supposed to wait for the diagnosis confirmation by pathology. So the treatment, now you could argue versus IV versus oral, or even if you're giving IV, you would give conventional doses. I would hesitate to give mega doses or 1 gram in elderly patients. I would still give conventional doses to these patients because your aim is to give steroids in the standard anti-inflammatory doses. I would give standard doses, IV to just give a one start and then shift to oral. The aim is to continue this for very long till your ESR starts coming back normal, and then only start tapering in these patients, which may take up to a year or more of therapy. So this is the way, as has been mentioned. Like I said, IV would be equivocal. I mean, is a little, can be decided either way. But yes, methylprednisolone or oral steroids and a long follow-up.
Dr. Mahesh,
So I essentially agree with all Dr. Rohit had said. And one more thing, I might involve a rheumatologist in the long-term care of these patients to assess the other parameters.
Right. And so any questions anybody has? Yes, before we...
So it's not standard of care to give methylprednisolone or any steroids in a traumatic optic neuropathy. Very early presentations, there is anecdotal experience, I won't say good studies, but that in very early, in the absence of any other neurological injury, giving IV methylprednisolone may help in the recovery.
But no mega dose.
But no megadose. I mean, the standard, you can give 1 gram as the originally described megadose were too high and has been found to have serious effects, especially in the presence of neurological issues.
So we should remember the crash study which said that severe head injuries we should not give. For example, if there's a CSF rhinorrhea, there is a skull base fractures, there is a communication, so it's better to avoid. No medical legal issues in that. We can always defend.
That's what I was about to say, that steroids can be given, but if it's a polytrauma, leave it to the acumen or the neurologist or the person who's handling it. So you can advise that it's required, but based upon the situation of the patient, you may give, because there's a risk of infection or something else which can come up.